Hi, my name is Kian Nguyen. I'm a dentist in private practice, but I also teach and do research at the University of Sydney. Today's presentation from me will be about antibiotic use in dentistry. As a group, dentists in Australia prescribe about 3% of the total antibiotic usage for human treatment. This is low by international standards. The literature has reported that in the UK and the US, dentists there prescribe between 7 to 11% of the total antibiotic usage. However, in the past 12 years, the number of scripts written by dentists in Australia has been increasing by about 50%, so we still have some room for improvement. In my presentation, I will go through a number of areas with regards to usage of antibiotics by dentists. I will go through scenarios where antibiotic use is controversial and scenarios where antibiotics has been used inappropriately. And then lastly, the potential consequence of the proposed measures on oral health will be discussed. So antibiotics used in dentistry, we use for a number of reasons. One, to treat the spreading of oral infection. Two, to treat post-operative oral infection. And three, to prevent oral bacteria causing infections in other parts of the body. One of the more common causes of oral infection is due to dental decay. This is a consequence of bacteria entering the nerve chamber through the hole created by the decay. This results in the death of the nerve. And as the bacteria proliferate inside the nerve chamber, some will emerge through the tip of the tooth into the underlying bone, causing an abscess formation. A second cause of oral infection is due to gum disease. This is where poor oral hygiene results in accumulation of plaque and tartar at the neck of the tooth. Bacteria proliferating on this food debris will cause inflammation of the gum. The underlying bone under the gum will retreat away from the infected area. The consequence is that there will be a deep pocket forming between the tooth and the gum where more food and more bacteria will proliferate. So a vicious cycle will set up. Eventually, when all the bone has been lost, the tooth will become mobile and fall out. The third cause of oral infection is due to impacted wisdom teeth. This is where there's insufficient room in the mouth to accommodate all the teeth. The overlying gum covering the very last tooth will trap food and prevent good oral hygiene. As a consequence, the bacteria will proliferate due to that retained food, causing inflammation and infection of the gum. All these infection sources can spread to other parts of the body. Oral infection can be a consequence of dental treatment. There are over 700 bacterial species in the mouth, and each meal of saliva can harbor approximately 100 million bacteria. With this mass of bacteria, it is a wonder that we do not see more oral infection due to dental procedures. For example, after tooth extraction, the underlying bone is exposed, but we do not routinely see infection of this area. As a consequence, routine antibiotics is not given to simple extractions or oral surgery to remove impacted wisdom teeth. Antibiotics are recommended, however, for people who are at risk, such as immunosuppressed, or if the surgery is extensive or performed in an active infection site, or when there are large foreign bodies are implanted in the bone, such as a dental implant. The third class of antibiotic use in dentistry is to prevent infection in other parts of the body from oral organisms. As you can see in this image, the plaque accumulated around the teeth will harbor billions of bacteria. During dental procedure, the gum is manipulated, and some of these bacteria can go traveling in the bloodstream to other parts of the body. In patients with damaged heart valves, some of the oral bacteria can accumulate around the damaged valves and grow into vegetations. These vegetations can grow and break off, traveling the blood to other parts of the body to block off the blood supply to cause ischemic disease such as a stroke. In other cases, bacteria in the mouth can seed the prosthetic joints and cause infection around the joints. In some of these cases, antibiotics may be useful to prevent seeding of bacteria to other parts of the body. Dental infection can have a serious consequence and is a burden on the public health system. Hospital records in 2014 and 15 revealed that over 65,000 admissions were due to dental infection, and 7 have resulted in death. Most dental infections, however, are localized to the problem tooth. For example, after removal of the wisdom tooth, the incidence of the tooth socket infection ranges from 4 to 30%, with abscess formation just over 1% of cases. Simple tooth extraction can result in 1 to 5% of the socket infection. Hence, antibiotics will be useful to control some of these infections. Antibiotics recommended for use to control dental infections are fairly limited. They include first-line penicillins, which are narrow-spectrum antibiotics, including penicillin V and amoxicillin. For moderate spectrum, antibiotics such as clindamycin, cefalexin, and penicillin plus clavulanic acid are useful. Some dentists may also prescribe erythromycin, but resistance from all organisms are increasing. For anaerobic infections, such as bacteria in gum disease, metronidazole is useful. And rarely do we use broad-spectrum antibiotics such as tetracycline. All these classes of antibiotics prescribed by dentists are subsidized by PBS, and sensitivity testing is rarely used in general dentistry. This is because the source of infection can be easily removed, such as removing the tooth or do root canal therapy. But by the time the results come back, the infection is usually cleared. There are controversial uses of antibiotics in dentistry, however, such as in prevention of local infection after removal of teeth, such as a wisdom tooth. Reports have indicated that without antibiotics, 11 out of 100 cases will result in localized infection. But with antibiotics, 3.5 of those patients will result in localized infection. The debate in dental circles is that, is this worthwhile to give antibiotics to prevent infection, or do we just treat the infections when they do occur? Another example of controversial use in dentistry is to use antibiotics to prevent infection when we place implants to replace missing teeth. Because implants are a foreign body, if there is any infection in the surrounding bone, the implant will be rejected and the implant procedure will fail. Reports have indicated that out of 100 patients, 6 infections will result in failure of the implants without the use of antibiotic prophylaxis. But should we give antibiotics during the procedure, only 2 infections will result out of that 100 patients. So the debate is, do we or don't we prescribe antibiotics to prevent infection? There are a number of scenarios when antibiotic use is not an appropriate course of treatment in dental circles. The source of infection is easily identified in most cases, and when we remove that source of infection, the body usually heals by itself. The reasons why dentists don't always remove the source of infection could be due to lack of time or lack of skill to carry out the procedure. The shift to cosmetic dentistry in today's practice meant that many dentists lose their surgical skills and become more reliant on the referrals to oral surgeons to remove wisdom teeth, for example. And they need to use script for antibiotics to control the infection in the meantime. Other practitioners may be slow to adopt new, more restrictive guidelines on antibiotic prophylaxis to prevent infection elsewhere in the body. And the impact of underinsurance or the cost of treatment itself may mean that the patient will opt out of definitive treatment and request a script for antibiotics to control the infection instead. In regards to the potential consequences of the proposed measures on oral health care, 1. If we make antibiotics significantly more expensive, this will have minimal effect in dental circles, as a lot of the antibiotics are PBS subsidized. If we increase the co-payment, then this may disadvantage the lower socio-economic groups. 2. If we prohibit antibiotics from being dispensed on the date of the prescription, well, urgent cases may be put at a serious health risk, and the delayed treatment may result in greater hospital visits as the case worsens. 3. Prohibit or severely restrict antibiotic prescription of last resort. This is of no consequence to general dentistry, as we rarely use these last resort antibiotics. 4. Ban the use of growth-promoting antibiotics in food-producing animals. Well, this will have no consequence to the clinical practice of dentistry. 5. Hang a signed poster in their consulting room pledging to only prescribe antibiotics when they are needed. Well, this will not be a barrier to dental treatment, but research will be needed to see if this method will translate to changes in prescribing behavior by dentists. 6. Requiring justification on the patient's record each time they prescribe antibiotics. Again, this is not a barrier to dental treatment, and it is implicit with good clinical notes, so we do recommend this to be done. It may need auditing, however, for compliance. To promote sustainable use of antibiotics in dentistry, there has been reports that the prescribing behavior of dentists can be changed through education. In one trial in the UK involving 795 dental practices, after auditing of the prescribing behavior and feedback to the dentist, a 6% reduction of antibiotic use was seen. In a different program involving 40 dental practices, after auditing and educating the dentist, total elimination of inappropriate antibiotic prescription was achieved. Other strategies to reduce reliance on antibiotic use in dentistry may include emphasizing primary health care. If we can prevent dental decay or gum disease in the first place, well, the source of infection will not be there. Providing definitive surgical treatment is another option. If the dentist can remove the source of infection rather than relying on antibiotics, that will fix the problem. Public awareness of antibiotic resistance and the patient to seek clarification from the clinician before they get a script of antibiotics may put pressure on the clinician not to prescribe and provide definitive surgical treatment instead. In summary, the availability of antibiotics in dentistry is necessary to control spreading infection when that arises. The use is fairly restricted to specific treatment of oral bacterial infection or prevention of infection. Most oral infections can be treated with no antibiotics by removing the actual source of infection. And the potential overuse of antibiotics in prophylaxis or preventive treatment, or due to insufficient operator time or skill to remove the source of infection, or misconception of effectiveness in certain clinical scenarios, can be prevented by education. And restricting access to antibiotics may pose a health risk and place greater strain on hospital resources if it results in late intervention. I'll be available to take any questions should you have any.